It's a bit longer than a case, but
don't worry.
I tried to keep it short.
Don't worry. Carry on.
I will only show the right lung because of the time, and it's the worst. So I thought it would be a good option.
Absolutely fine. That's not a problem.
Okay.
You can share your presentation. We've still got 5 minutes, so we'll just give everybody 5 minutes before we start. Go for it, Anna.
Okay. So I will present a case of a preterm of 27 weeks, around 1,000 grams at birth. The mother had diabetes during pregnancy, and there was no time to do the antenatal steroids complete, only to do dexamethasone doses. It was an unstoppable vaginal delivery, and the baby born needed immediate resuscitation with a PRAR of 478, and was transferred to our unit in the first hours of life. He did the Curosurf. And I showed these before. These are the pre-surfactant scans with a sectorial probe. One is right, the other is left, and we can see that is a white lung all over the lung, and with some maybe small subpleural consolidations here. So he did surfactant immediately. He was on 100% FiO2 and high frequency oscillation. This was the X-ray in the first hours. And then on the day 4 of life, I repeated the scans. I will show only the right scans in the half of time, but we can see that there is sliding in all the fields. The pleural line is a bit thick, maybe sometimes irregular, with predominant B lines. They are not so compact than in the previous scan. We can see some A lines. I'm sorry, I have here okay. Here some A lines are free, and sometimes I think we can see it here also.
Yeah.
And maybe because of surfactant, I think we can see a double lung point here. We have more compact B lines and better in the upper part of the scan, in the left part of the scan, with more A lines. And I classify this as a heterogeneous lung after surfactant. I think
Lovely. Just one comment, Anna.
Yes.
Looking at R1, if you go to the extreme left of the image at the top, yeah, beautiful. So can you see how irregular the pleural line looks?
Yes. Yes.
Yeah. And basically, as you go down into the middle, you can see what looks like an area that kind of could resemble tissue, but definitely in the middle, there is probably a deep consolidation. If you just bring your arrow down, just and below that, yep. Again, the question that I would kind of ask myself is, do we have a collapse consolidation here? And whether you might have a right upper lobe collapse consolidation. It may not be, but the only other comment I have is that when you look at the density of the B lines adjacent to that area, so you've got a B profile, yeah, just there, it becomes really dense. I'm going to talk about this today. And I just wonder whether you've got a consolidation with maybe a right upper lobe atelectasis. But
and
maybe
also?
Possibly. I think the problem that we have over here is you've got rib coming in, and I just wonder whether the shadow next to it, again, you have a little bit of atelectasis there. It becomes quite dark and it's quite dense. So possibly, yeah. And I mean, definitely R2, you've got a complete B profile with what look like our compact B lines, subpleural consolidations. But yeah, you're absolutely right. Yeah.
This was the X-ray, and really the TET is a bit low, so probably it should be like that. And but 3 days later, I think it's more evident here that there is something.
Definitely, yeah, absolutely, no doubt that right upper lobe is absolutely no doubt. And this is the beauty of lung ultrasound, and that, I mean, my gut feeling is you probably was a consolidation appearing on that, maybe not an atelectasis, but that's the challenge of differentiating the two. And I'm going to give you some pointers. You did see pleura. If we just go back to the previous image, and so the previous slide. Yes, please. Now, if you look at the previous slide, can you see how you still see pleura? So there is an element of aeration that you see there. It's quite irregular. And again, that in my mind would favor more of a consolidation as compared to atelectasis. It does disappear towards the top end, which kind of raises. Often they coexist, but clearly the consolidation is visible on the right and again in the middle lobe. And as you go down to the next slide, it's fairly obvious. Tissue sign, definitely static air bronchograms. The pleura is completely knocked out. And, I just wonder whether you've got a decent sized consolidation in that right upper zone.
Yes.
Yep.
Dear.
Yeah, definitely. The beautiful images. I just, again, just for my colleagues who are currently kind of reviewing the images here, can you see how the depth has got uniformity about it? These are exactly the right gain settings. You can make a very good diagnosis, starting from that sign at the top to the pleural line. Very nice B lines that are visible. So you're using a GE. What's the frequency of your
Yes.
probe?
It's 12.
Yeah, so very nice image for a preterm baby. There's nothing I can say to improve this. It's perfect. Yeah.
May I ask one question?
Please.
Yes, just is that on R1 the left image? So is that hepatization? This
Yes.
hypoechoic lesion in the middle?
No, the entire area is hepatized, and then I mean, my gut feeling is you've either got dropout there, or you've got an atelectasis, which is why it appears that way. You've got this area, and what I would do in this situation is, again, I would put some Doppler on it. I'd be very interested to see what the vascular supply like that. What was the CRP in the baby at this point?
It was negative.
Okay, that's really helpful. So again, I just wonder whether you have an element of atelectasis that is giving you that appearance. Now, when the baby breathes in, the lung expands, gets aerated, but when the baby expires, that entire zone probably just collapses down because there's air coming out of it. And I'd probably say you've got a mixed collapse consolidation there, but we'll talk a lot about it today and you'll have a lot of practice, guys. You will all be practicing quite a bit. Yep.
Because here I was in doubt that this was moving in and out.
My gut feeling, and I'll show you what clear cut is. I think that's a static air bronchogram that you see. Okay. I don't think that's dynamic. I think that's static. And what I'd say is, guys, don't feel too stressed. You know, maybe with the IFA, there are a few regions that do look like they're moving in and out. At the top in particular, just under the pleura. But really what you're kind of thinking of at this point is dynamic air bronchograms they're fairly obvious. I think there's probably a mix of dynamic and static, but more static than dynamic. And really just beneath the pleura. So if you draw a line opposite R1, so go to the top. Yeah, those, so just come a little bit lower. Can you see how they move? These ones look a little bit more dynamic,
yes.
But actually if you come to the big area below, that's a static air bronchogram, in my opinion. It's in one place, not moving in and out, but just the ones above, there are some regions where you have some dynamic air bronchograms. And again, my worry at this particular point is that mnemonic consolidation. Because you've got static and a few dynamics, and I would definitely Doppler that region. You see CRP was still negative?
Yes. Okay. In this day, yes. I didn't do Doppler, sorry.
No, that's okay. Don't worry. Going forwards, what I'd say is there's a really good opportunity now, and we'll talk a lot about Dopplers today. Yeah.
Okay. So.
Very nice image. Beautiful. So just my colleagues
after,
here, yeah, sorry, carry on. I'll interrupt later.
This is the rest of the lung, and I think here we can see also in R3 in the upper part, maybe a collapse.
Yep. I'd probably say both collapse consolidation. So in R3, you've got two zones. You've got an upper zone. The pleura is completely gone. It's a beautiful image. Okay. And you've got static air bronchograms. I'm not really convinced you've got dynamic air bronchograms. But if you come to the lower half, just the lower half of that image. No. Just, that is consolidation.
Yes.
So that is a right-sided collapse consolidation. And you've got atelectasis, is my impression, in the upper zone. Again, really good to put Doppler on it, because if you put Doppler on it and there's no vascular supply, then that, a complete absence of vascular supply with absent pleura at the margin, static air bronchograms, a lung pulse, if you can see it. Should we just play it again? Let's see if you've got a lung pulse there. Yeah, difficult to convince myself, but those would be classical features of what I would say is atelectasis, collapse. So that's beautiful. Again, very nice images, very, very nice images. Yep.
And three days later, they disappeared. So I think maybe it was really a collapse. You can see that it's better. And then we see the pleural line here.
Did you make any changes to ventilation at the time? Did you try to recruit the lung a little bit more?
He was intubated in the last ones, and now he was in no-invasive ventilation. So
Sure.
less support.
Okay. Is there a shred sign there, do you think?
I think so.
Yeah. Now, just a few comments about shred sign that are very important. Now, I know that a lot of us talk about shred sign and try to correlate it with mnemonic kind of clinical appearance of consolidation. I have seen shred sign in evolving bronchopulmonary dysplasia. I've seen shred sign in BPD, and in particular with meconium aspiration. Babies with in utero meconium aspiration, where you have consolidation, where there's inflammatory change. So it's not just pathognomonic. I would not even use the word pathognomonic. I think I would always say that if you have shred sign, it raises the possibility of pneumonia. Please clinically correlate. Now, clinically correlate means your CRP might not be, just remember, pneumonia, and especially congenital pneumonia, if babies are not bacteremic and don't have a massive inflammatory response, your CRPs might not always be elevated. If you're tachycardic, if there are other signs that make you worry about potentially sepsis, you could still have a mnemonic consolidation. You could have infection. And a lot of babies often with chronic lung disease who are chronically intubated, often are colonized with bacteria, could have a mnemonic consolidation, but they're not sick enough to put their CRPs up very high. So don't completely exclude mnemonic consolidation because your CRP is normal. Now, if you Doppler this region and you see a lot of vascular supply there, again, that's basically an indicator that there's an ongoing inflammatory process. Chronic bronchopulmonary dysplasia, where you have chronic lung disease, again, would kind of maybe not give you a very vascular kind of an appearance to the consolidation there. So use your Dopplers, have a look, and we'll show you what the Doppler appearance might look like. But these are beautiful images, Anna. What about R3? I'm very curious to see.
Is better with A lines appearing.
Yep.
And I think there are no consolidations here. We see the pleural line.
Yep. So again, just evolving RDS, the subpleural consolidations that you saw initially have kind of disappeared. And in the evolving phase of BPD, a lot of these babies, they may have alveolarization and grades of subpleural consolidation, but I mean, my clinical feeling is I think this baby is actually getting better. I wonder what you thought.
We'll see next.
Okay,
fair point. Is going to be with more subpleural consolidations here. And it was equal in all the lung, the left two. R3 is better, but I think he is evolving to chronicity.
Sure. Yep.
Compact B lines and these subpleural consolidations.
Sorry. My apologies. My apologies. Please carry on. Yeah.
And we keep seeing this in the next days. Here the baby was worse again. He needed to be reventilated in assist control, doing apneas and bradycardias. And the pattern of the lung was similar with B lines and subpleural consolidations. Some A lines here.
Yep.
So, but I think it's the next day. We have really a consolidation here.
Yep.
And we isolated Klebsiella in respiratory secretions, and the CRP not so high, but was not negative.
Yep.
And we treated with like a pneumonia on the right, and we have the X-ray here.
Yep. The shred sign definitely visible there. So
Yes,
would you
and
like to
it's
show everybody?
It's a big consolidation,
Yep.
more than 2-3 intercostal spaces.
Yep. I would
Here
agree.
also.
Yeah,
Same
very.
here.
Yeah, not so nice for the baby, but again, shred sign, and that is the interstitial appearance of the lungs with very classical compact B lines, but they kind of coalesce together. So subpleural consolidation. Yep, I would agree. Yep, a little bit of lung aeration in the right lower
Here.
lobe. Yep.
Yeah.
And if you look at the X-ray with the eye of faith, actually, most of the top half, but there's a little bit of aeration there at the bottom. So yep.
Yeah. It corresponds.
Yep. Beautiful.
So,
oh dear. Okay.
1 month life.
Yep.
That is keeping the pattern of a chronic lung disease. Is now on non-invasive ventilation again, but needing FiO2 around 30% and always with a CO2 a bit high. But I think there are more A lines and the B lines are not so compact.
Yep.
And the subpleural consolidations are less and smaller.
Yep.
They're smaller.
Still on antibiotics or finished?
He finished here.
Finished.
Already.
Okay, that's fine. Yep. So less shred sign also visible. That's one of the things in terms of response to treatment. That's yep. Very nice. Beautiful images, Dr. Anna.
Thank you.
Any questions, guys? Okay, that's really kind. I am going to ask our next colleague to share images, and on my old brain, I will just have a look, and that is Dr. Shankar, please. What? Yeah, Dr. Shankar. Please go ahead and share. I think the images are beautiful, and I have nothing to say about image optimization. Yeah.
Can you hear me? Hi.
Oh, I can hear you, Dr. Shankar. How are you? Are you okay?
Yeah, I'm good. Yeah. So I think I'll just say I'm Shankar Narayanan. I'm a consultant neonatologist at Watford. I'm just trying to share my screen here. Can you see my screen now?
No. Take your time, don't worry.
Okay. Yeah, I think I'm there. There's some max security settings was coming in. Can you see it now?
Yeah,
Yes.
absolutely.
Okay.
Very nice.
Yeah, so yeah, it's a case of a 30-weeker. I got serial ultrasounds over the first 3 days, and really after attending the sessions and going through some practice, I think one of my colleagues, Naz, as well, is in this course. So we both are sort of trying to establish lung ultrasound as sort of a practice in our unit, which is a level 2 unit. So this case was a 30-weeker. Mum came in with PV bleed and some concerns over fetal movements over a day or so. The obstetrician thought the CTG had reduced heart rate variability, so they went for a emergency cesarean section. But they managed to get 2 doses of steroids and also gave magnesium. So baby was born in fair condition. We were able to do deferred cord clamping for 1 minute. Started PEEP and CPAP very soon after birth. And the baby was on 28% oxygen on arrival in the neonatal unit, about 15 minutes of age, with mild increased work of breathing and maybe intermittent grunting. So we did the ultrasound at 45 minutes of age, almost like a golden hour sweep.
Well done.
Used the hockey stick probe on a GE Vivid IQ, depth of 3 to 4 centimeters and frequency 16 megahertz. So the baby was prone, so it optimized everything. We put the baby on prone position. So started off with the posterior views. So as you can see, R5 and R6, and on the axilla as well, all compact B lines. And in the R5, I think there is some subpleural consolidations.
Absolutely.
On the upper part. So we tried to use the score as well. So I thought, it was 2 all over.
Yep.
And then on the left side as well, similar compact B lines, and some on the upper left, possible some subpleural consolidations. I wasn't sure whether there was some dynamic bronchograms as well on the upper part or just some subpleural consolidations. And again, I thought, 2 in each segment. So
just going back to your images, just to the, so beautiful images, really nice depth penetration for a 30-weeker, up to 4 centimeters. You can see the entire image. The footprint is very nice. Even with a hockey stick, you're getting at least around 3 intercostal spaces. You can see clear pleural sliding with subpleural consolidations. You could have the focus a little bit lower, just at the pleural line. So your focus it's in the soft tissue.
Yeah, I had one question, because when I was trying to move the focal point, it moves by 1 centimeter.
I get it. Yeah. And the challenge is, especially in the upper lobe, you tend to lose contact. So the best way to try and do that is just move your probe a little bit to try and get alignment of the pleura with the focus. This is especially challenging in extremely small babies. What was your baby's weight?
This baby is 1.3 kilos.
Yeah, so smaller side. But for me, very good. I can see subpleural consolidations. Not convinced about the dynamic bronchograms. I think those are subpleural consolidations. So, but definite subpleural consolidations.
So then when we totaled up the score, it came to 12, and what I learned from the literature and this course, thought, okay, now the decision point, whether to give surfactant to this baby or not. Baby's on 28% oxygen, some mild increase in work of breathing, had adequate antenatal optimization. And clinically, I thought, although the lung ultrasound score was suggesting that I should give surfactant, I thought I'll just wait and see.
Yep.
And we did not do an X-ray because reasonably confident with the fact that we're not dealing with a deteriorating baby with pneumothorax or anything, so we didn't do an X-ray.
My compliments, sir.
So the baby was between 28 and 35%. Each time the baby was handled, the FiO2 went up a little bit and then settled down, more comfortable on prone position. Blood gases were in the normal range and hemodynamically stable as well. We were able to give some donor human milk, and the baby was tolerating that as well. But as I went off shift, and the night team didn't have ultrasound skills, but as well, whenever the FiO2 went up, they were a bit concerned, so they did an X-ray at about 22 hours of age overnight, and that showed sort of moderate to severe RDS, and almost saw some mild PIE type changes as well. So this was like very close to the morning. So I had a sort of phone call to say, should we give surfactant? And I said, okay, I'll come in a bit early and repeat the ultrasound. So this ultrasound was done around 23 or 24 hours of age. So the baby was supine this time. So I could see, a lot of improvement with the, aeration. with an alveolar interstitial pattern. You could see predominantly on the R1 more of an A line. The compact B lines have gone. Now we just see non-compact B line. Similar on the R2, and R3 and R4 had compact B line still.
Yep.
So lung sliding throughout. So scored 1, 1, and 2. And on the left side, as well, we
very nice
alveolar interstitial pattern.
But better aerated lung, absolutely no doubt. Right and left, and I mean L3, L4 looks virtually normal.
So it was very interesting because 3 hours before they were worried about the giving surfactant with after an episode of handling the baby having oxygen requirement going up to 40% and grunting, but then within 2 hours this ultrasound was done and was actually showing improvement. So the score was 6. So we continued to manage on CPAP, and then the baby sort of turned around from that point. And if I were to stay less than 30%, we actually switched to high flow oxygen, and feeds were tolerated. So about this ultrasound on day 3, and again, continuous improvement. And here you can see a double lung point.
Yep.
On the R1 and R2, R3 and R4 were. Again, you can see alveolar interstitial pattern, both A lines and B lines.
Yep, beautiful images. Yeah,
and the similar picture on the left as well, predominantly A pattern now.
Yep.
So my learning from this was that doing it much earlier on, this golden hour sweep meant that we were able to assess the severity clinically and also corroborate it ultrasonically. But then I had this little confusion about, should I just give the surfactant because lung ultrasound score is above 8. But then we're going through this learning phase. I just thought, wait and see what happens, and then this baby sort of turned around.
An absolutely beautiful case. My compliments, Dr. Shankar. Again, showing you how you can use serial lung ultrasound to help guide your clinical management in this particular situation. Now, as I kind of discussed in the cases when I presented Lisa and kind of how we do decision making, I think what you've considered is that this is a baby who's had perinatal optimization surfactant. Was it a girl?
No, this is a boy. It was a boy.
Okay, so probably a very nice boy, I must say. But experience kind of says that you've considered, taken all those facts, but the clinical kind of presentation into account. My only question: so when the baby clinically deteriorated, did we ask the nurses whether there was any handling? Some of the situations, sometimes what happens is prongs get dislodged, the baby's not getting effective PEEP, and clinical symptomatology gets worse, but actually the lungs don't necessarily get worse. Once that's corrected, the aeration actually gets better. So, small things like that can actually affect your clinical kind of situation. But doing a lung ultrasound in that situation, even with the deterioration, gives you a high deal of confidence that actually, even with that, the lungs are actually getting better. So there's an opportunity for you to give this baby more time. Yeah. Now, the challenge from our perspective is, and this is where I would say we need to use lung ultrasound scores looking at the holistic picture. My gut feeling is, I think if you had not given that baby antenatal steroids, I think if you were kind of in a situation where this baby was clinically working hard, those are factors that would almost certainly push me towards using surfactant with a lung ultrasound score above 8. But I think if you make this baby 32 weeks in the way you're clinically describing it, and it's perinatally kind of optimized, I might actually give the baby more time and repeat another lung ultrasound. And especially in the context of settings where surfactant is quite expensive, like if you're in India and the patients have to pay for it privately. The one risk, obviously from our perspective, is delayed surfactant. You might have less effect. There is a slightly higher risk of developing a pneumothorax, but the risks and benefits kind of assessed. This is a good example of where you've used serial ultrasound and had an absolutely beautiful outcome. So my compliments. In terms of, I think your images are beautiful, good depth, good penetration, really nice gain settings. I think, as you can see with the latter images, you've got your marker at a good pleural line margin, which gives you a really nice pleura. And, I have no other comments. I think your images are beautiful. Thank you so much.
Thank you.
Thank you for sharing such a nice case.
Thank you.
You have
another case? Do you have time or?
Okay, go for it. Because Rana's not presenting today, Dr. Rana. So we have time. Yes, please.
Okay, thank you. So this was this is a term baby.
Sorry. Yeah, is it the same presentation? Because you're not in slideshow mode?
Can you see it?
No. So we've got your slide presentation, individual slides. Maybe you'll have to stop and then share again.
Oh, okay.
Any questions from the audience while we're waiting? Yeah, we can see your slide presentation. Just have to go into slideshow mode. That's it. That's beautiful. Very nice. Thank you, sir.
So, so this is a case of a post-term baby born by emergency cesarean section because of maternal fever and high white cell count. They thought mom had sepsis, and there was also meconium, so it was an emergency C-section, category 1. This baby developed respiratory distress soon after, and about 60% oxygen to stabilize the transition. Didn't need any other resuscitative interventions. So the team who attended put the baby on a PEEP, and then oxygen brought the baby to the neonatal unit, and the baby was straight away started on high flow oxygen. So the concern from the team was that this is meconium aspiration syndrome because of the history. The baby was on 6 liters of oxygen, 23% FiO2, saturating really well. No, there's no grunting, mild intercostal recessions. So the plan was to continue to give high flow oxygen, sepsis screen, and antibiotics in view of maternal history. But there's a lot of concern that this is meconium aspiration syndrome. Therefore, despite the baby being relatively well and the respiratory distress was mild, the team wanted to keep the baby on non-invasive respiratory support, high flow oxygen in this case. So when I came to know about this baby, just put the probe on at about 1.5 hours of age. Same hockey stick probe with a depth of 4 centimeter, this being a term baby. So on the right side, I could see good lung sliding, and A and B pattern. The B lines were more than 3 in a segment. Same in R2 as well. And here you can see a double lung point on the R2, and predominantly an A pattern with some non-compact B lines on R3, 4. So I gave a score of 1 on each segment.
Yep.
On the left side, predominantly A lines here with some B lines, and same in R2 and L2 and L3, L4 as well. And again, I gave score of 1, 1, and 2. I wasn't sure whether there was some subpleural consolidations as well in both.
There are. You're absolutely right. There are. Yeah.
But because predominantly the pattern was of an alveolar interstitial pattern, I made a diagnosis of TTN rather than meconium aspiration syndrome as clinically it was thought. So we didn't go for a chest X-ray, and within a couple of hours we discontinued high flow oxygen, which the baby tolerated, and the baby went back to mom.
Yep. My only comment is subpleural consolidations would not normally be present in TTN. My gut feeling is you probably do have an element of fluid transitioning lung, but I wouldn't hesitate to maybe make a diagnosis of maybe mild meconium aspiration with the subpleural consolidations.
Okay.
So and again, the real question over here is, somebody might argue, well, that's semantics because we have to follow the baby up clinically. And actually, from our perspective, the people who argue that, well, we don't need to do a lung ultrasound, would kind of at this particular point say, well, what have we achieved by this? But actually, I'd say you've achieved because you've demonstrated subpleural consolidations, which would not necessarily be a feature of transient tachypnea of newborn. Clinically, you've got transitioning lung, but mild meconium aspiration definitely a possibility. And a lot of babies, we do meconium ops for 12 hours. Some of these babies do have mild meconium aspiration. And really, the babies who, with the fluid resolving, actually often become much better. So beautiful images. I wouldn't be able to get better myself. So, my compliments. Well done, sir. Yeah, yes, please.
Can we see again the subpleural consolidations, please?
Yeah, sure. So do you want to play those images? So what I'd say is that if you look very closely, in particular in the middle, you've got these areas. So that's a B line, but just to the left. For me, you've got slightly dense subpleural consolidations there that are separate to the B lines. Just move to your left. Yeah, left, little bit more. So that area there, 100% for me, you've got subpleural consolidations there. Just that and adjacent to the left, those areas. And again, what I'd say is that it's a very dense B line on the right side that's coming below. But I would say that I really worry, even I'd say in the image on the left, whether you have some subpleural consolidations coming in.
Yeah. But the baby was clinically very well. So we decided we would not...
your management is absolutely appropriate. And I would have loved to have seen a chest X-ray for this one. Seriously. It would, and that's the beauty of lung ultrasound while you're in the learning phase, is that even now, most of us, once you're starting to do lung ultrasound, you develop a little bit of, I would say, ego, where you really want that chest X-ray to try and confirm, well, is this TTN? Is this kind of meconium aspiration? I would have loved, but I think your clinical management and my gut feeling is, mild meconium aspiration would be high on my list. Yeah.
Another thing as well, I see is that, the staff confidence is a lot more after we have done the lung ultrasound and say that it's okay in terms of weaning off the oxygen. So I could see that within our unit, the nursing staff, warming up to the lung ultrasound findings and, how, when they look at the screen as well. And now we are seeing more staff asking for, are you going to do a lung ultrasound?
Very nice. I mean, I think that's fantastic. And, I'm glad that you're being able to take it forwards. And, it would be very interesting to see what others think and what kind of resistance they're getting. But my compliments there. So our next colleague today is the lovely Mayank. You're all lovely. Mayank is a little bit extra lovely. Yeah. I've got a hand up.
Sorry, just got a question about the case just presented. Very nice case. Why did we consider that subpleural consolidation as meconium aspiration? Could it be just a pneumonic consolidation? Especially with the antenatal history.
Yep, clinically, what I'd say is few things. And we'll talk a lot about consolidation today. Mnemonic consolidation in particular can have three kinds of presentations. So you can have subpleural consolidations as you see in meconium, as you see in RDS, often with a fractal and a shred sign. I think the other aspect to management, you can have translobar kind of consolidations with shred sign, which again have an irregular pleura. My only question here and points against, I have no fractal sign or shred sign. The pleura looks relatively regular throughout. It's continuous. We don't have any discontinuity, no evidence of deep consolidations, again, which really help to make that diagnosis of kind of mnemonic consolidation. And we'll practice a lot of it today, Dr. Rana. I think clinically, I would say based on the history, my points, I would favor more of a diagnosis of meconium. Maybe mild RDS can also be argued over here. But I think with the history, if I'm clinically correlating and somebody said, well, what would you like to keep as your differential? I'd probably put mild meconium right up there, transitioning lung along with it. I think with the subpleural consolidations that I feel are visible, I think TTN is less likely. And for mnemonic consolidation, I just do not have enough of either fractal shred sign or irregularity of the pleura or deep kind of consolidations to kind of point me in that direction. Does that help? But we will see a lot today. You'll practice a lot.
Yes, that was very wonderful. Thank you.
Dr. Mayank, please go ahead, sir.
Yeah. Am I audible?
You are audible, sir.
Okay. So this was baby who was referred to us on day 2 of life with history of perinatal asphyxia. So the baby was born at 40 weeks with a birth weight of 3.7 kg, and the baby was born through vaginal delivery. This baby was born through meconium stained liquor, was non-vigorous. Baby also had hypoxic ischemic encephalopathy, stage 2, according to Sarnath staging, and also features of multi-organ dysfunction. So the baby had shock, AKI, DIC, subgaleal hemorrhage, and transaminitis. The baby was intubated since birth, and currently the baby was now 90 hours of life. The baby was comfortable on SIMV plus PS settings, 12/5 with FiO2 of 21%. And the baby had the spontaneous rates of 40 to 50 per minute and was basically very comfortable, no retractions as such. And the seizures were also passive by now. So I had done this examination with a L25 linear probe at 9.5 megahertz. The examination, I was mainly focused on the right lung because of this finding. So the baby was on extubatable settings, but this X-ray done around 12 hours prior had shown right upper lobe collapse. There's a sharp margin, and the tube is slightly in, so probably that might have been the reason. So I wanted to see, the baby was already started on chest physiotherapy. I wanted to see if it has resolved, and that might have resulted in a better respiratory findings in the baby. So I had imaged the right side only for this child. So this is R1 and R2.
Yep. It's definitely not resolved. Yeah, go for it.
So,
yeah, go for it.
Yeah, so I cannot see the pleura at all in the R1 image. So I can see, and I can easily make out that these are static bronchograms. I do not see any kind of movement. These are I would say classical static bronchograms all over. And there's some compact V lines which I can see in the images below. The R2, there's A lines which I can appreciate in the below parts, but I feel again in the upper part of R2 I can see consolidation. I was not so sure if I would call them consolidation, but I felt that since it was in continuation with the previous one, so I had labeled it as consolidation. Again, I would say the profile is C profile in R1 definitely, and in R2, if I take into account that this is consolidation, then the major part is C profile along with A profile in the but R3 and R4 was absolutely fine. There was adequate lung sliding, A lines, and this lung was completely aerated.
Can we just go back to R1 and R2? I mean, it's an absolutely beautiful image. And just looking at R1, you can clearly see that the pleural line disappears completely towards the left of the image. Below that, you've got lung that basically is hepatized with what I'd say is static air bronchograms. Just when you go below to the right side, just there. Yeah, beautiful. That's a deep consolidation. Again, with a static bronchogram, lung parenchyma. And when you go to the extreme right, so just go to the pleural margin, please. So yeah, so that's pleural margin, and that's one big coalesced kind of B profile, which basically is the consolidation again. And we'll talk more about why it's a consolidation. So you've basically got right collapse consolidation, and often you will find them together. But the reason that I would say that that is atelectasis is because when you have atelectasis, your lung is completely collapsed. Now, when it collapses, what happens is there's air that's trapped inside it, but no air that can come in and out because the bronchus or the bronchiole that's supplying it is completely occluded. So you get trapped air, which creates the static air bronchograms. And because air can't come in and out and you can't aerate that area of lung because it's collapsed, the pleural margin completely goes. And just remember, in utero, the first images that you take when the lung is completely collapsed, the pleura is not established. The pleura only establishes after the first few breaths. So the top half of that R1 is what is atelectasis. It's a collapse, but the deep half has consolidation. Deep half. So if you just bring it down, your arrow down. Right. Yeah, deep half, there. And then you have consolidation just below it. But the reason it's a consolidation is it's aerated. You know, air is being able to get in there, which is creating the pleural line. But the interstitial fluid in that area, obviously, because consolidation can have interstitial fluid around it, and I'll explain how, gives you the lower part showing a kind of a consolidation. It's a beautiful image. And it's more visible in R2. Please carry on, sir. R3, R4. Yep.
So I had formally, so my interpretation was collapse in the right upper anterior area, and the same on the X-ray, and the diagnosis was the same. Still, we went ahead with extubation since the baby was on minimal settings. So the baby was successfully extubated and tolerated well, and the chest physiotherapy was continued. And I followed up 24 hours later as well. I do not have the images though, but there was
you didn't save them, or you didn't save the images, or because you could show them to us next time.
No, I haven't saved the images.
Okay, that's
this was a very old case, so this is probably 20 days back.
Sure. Beautiful. Very nice.
That's all from me now.
Thank you. I'm so grateful. I think everybody has shared beautiful cases. There's very little for me to image optimize. And I think it's just to say, guys, you can see how well everybody is progressing. You know, it's something that I feel really happy about. And I would humbly request, guys, if you're not able to present, try to see if you can image anonymize and present, because it's really helpful. We all learn. The last person presenting today is the lovely Sarah.
Hello, are you hearing me?
We can hear you, Sarah. Thank you so much.
Hi, everyone.
Can I ask you just one question about the last slide?
Please.
I don't know if you see in the R1, there is a small hypoechogenic part in the upper part of the collapse. So this is a pleural effusion. We consider it, or we should not consider it as a pleural effusion?
I think you're absolutely right. The question is whether it's a pleural effusion or not. It's a little bit tricky for me to say because I'm not doing the scan myself. And my gut feeling is it could be a small pleural effusion. Yes.
Thank you.
My only comment is it's a little bit unusual to have not been in the rest of the lung. So I'll give you an example, Mayank. So what I'd say is that for me in a supine baby, the pleural effusion would be demonstrated best in the R5, R6 regions, not in the region that you're currently describing. That's the point against it.
Yeah.
So that is why I would say is it possibly artifact, or is it just an area where the pleura, because you have complete lung atelectasis, is appearing hypoechoic? And I will explain, because I'm going to show you some really nice images. So for me, I would say that it's possible. If I was doing the scan, I'd be able to tell you better, but I don't think it is. I think it's just subpleural atelectasis, which is giving you that appearance. And when I show you images today, you'll be able to understand better. Go for it, Sarah, please.
Okay, so this is a quick case.
Sarah, have you shared it?
No, I'm sharing. I'm sharing. Can you see the screen?
Yep.
Okay. So this is a quick and simple case, I think. This is an outborn male, late preterm, was born by a vaginal delivery with a preterm and premature rupture of membranes. And after birth, he developed a respiratory distress with hypoxemia and apnea. And so he was intubated and ventilated about in his hour 30, and he started antibiotics. He was transported to our NICU, and in admission, he was ventilated, and he was worsening, and his FiO2 at a maximum of 70%. And we gave him 2 doses of surfactants. And when I was in the NICU, I made the lung ultrasound, and this is about in his 48 hour of life. So 4 hours after the second dose of surfactants. So this is the right images are one. I think the pleural line is regular because the focus, like you can see, is a bit malpositioned. So we can see some blurred line, but I was in doubt here if I can call some subpleural consolidations, and I think they are present here. No consolidation, but subpleural. And lung is sliding, and I would call it this B profile. In R2, I think I can have the same description of the image, although I can see here A line.
Yeah,
but
my only comment, Sarah, is just your focus is well below the pleural line.
Yeah.
And for that reason, your pleura appears blurred.
Yeah.
And it's a little bit tricky about the subpleural consolidations. My gut feeling is they're probably there, but they would have probably been better seen if you had your focus at the pleural margin.
Yeah.
I completely agree. You've got B profile with the occasional A line coming in.
Yeah, I forgot, nice. but I corrected in the left lung when I
no.
realized that.
Well done.
Yeah,
well done.
And this is R3.
Yeah.
And here we can see the same profile that we saw in the last images. In the left lung, the focus is right.
Perfect.
Yeah.
And you can see the pleura very nicely.
Yeah.
It's regular.
Regular and the compact B lines. And here I'm in doubt because I think there are no subpleural consolidations or some micro. I don't know.
My gut feeling is let's see what the group thinks. Guys, show of hands.
I would like to see it to discuss my diagnosis.
No, absolutely. So let's go through everybody. Dr. Hassoun, what do you think?
I don't see any subpleural consolidation in this image.
Dr. Latifji?
I can't see any subpleural consolidation in the first image. For me, there is no subpleural consolidation.
Okay, I will reserve my opinions. Dr. Anna, Dr. Vaz?
I can see it also, but it's a bit blurred, L2, but I don't know.
Hand on your heart, kind of, if you had to go one way or the other. I just wonder whether in L2 you see comet tails with well-aerated lung. I'm not convinced you can see subpleural consolidations. That's just my thoughts. But Dr. Didier?
Yeah, I think I don't see any subpleural consolidation. I agree that images are B lines.
Okay. Dr. Galia?
I can see some pleural, subpleural consolidation.
Okay.
And
Okay.
this be yeah.
Sure. Okay. Really helpful. Maria, what do you think? Don't worry, we might not be able to have Maria. Dr. Rana?
I mean, on the image on the right, which is image number 1, there is this echogenic area just right in the corner. And I wonder whether that is just an exaggerated A line. I just needs a bit more interrogation of that area. On the other image, which is image number 2, there is this, I don't know what that is being referred to, the one just under the heart shadow, which I don't think we should consider that as a consolidation because it's not
Completely
behind
agree.
the pleural area.
You don't have a
behind.
bat sign. It's not, I completely agree. So I wouldn't interpret that. But just in terms of subpleural consolidations, what's your feel?
I think the pleura on the right side does look a little bit thickened, does look a little bit irregular. Some comet tails as well. Not enough to say there is consolidation there, I would have thought.
Sure. I'm going to kind of, just because I think the majority is coming out, and I would probably agree. I'm not really convinced about subpleural consolidations, but it'll be very interesting to see whether have you done the back by any chance?
No, I could not.
No problems. That's okay. That's absolutely fine. And was this the only scan, or did you manage to do a kind of a repeat?
No, because this is at 48 hours of life, and we did the X-ray.
Yeah.
But then I put this here, but this baby did very well, and 24 hours after he was extubated and on air.
Okay, very interesting. It's a very interesting case, and I think clearly what you can see is that, as Nadia mentioned, there's kind of an overlap with some babies. So mode of delivery of the baby in gestation were?
Vaginal delivery, 34 weeker.
Established labor?
Yes, vaginal. Yeah, the labor was because of the premature rupture, and then the baby was born.
And the chest X-ray that you showed us is kind of at what age? It's at
much of the same time, 46 hours, 2 hours before the lung.
Do we have any X-rays at birth? Just curious.
No.
No X-rays at birth. Okay, fantastic. So, yeah, I mean, for me, that looks like RDS at this particular point, clinically and radiologically, from what you're describing in the clinical course. And I think it just highlights that sometimes it can be challenging. I'm not entirely convinced I can see subpleural consolidations.
Yeah.
And my only comment is that if you've done an early lung ultrasound, I mean, you've given the baby surfactant, and surfactant naturally would affect how the lung appears. Subpleural consolidations are a reflection of atelectasis in that region, alongside the fact that you will have lungs that basically have hyaline membrane obstructing, causing the consolidations, and just whether surfactant can then alter the lung ultrasound appearance, because natural course of RDS also shows improvements once you give surfactant. So that's the only thought that comes to mind at this particular point, that you may well have had a clinical presentation with RDS, but because you've given surfactant, it's whether that obviously has improved the lung appearances. That is my only thought. But very good images. Again, good penetration, good gain settings. I think everybody has done very well with the gain settings today, just minor things. So my compliments.
Thank you.
So what I'm going to do is I will share my presentation today. We're going to have an interesting discussion on collapse consolidation. I'll just open my presentation up. Okay. Now we're in trouble. Can you see my screen and is my presentation visible?
Yes.
Yes, we
Excellent.
can.
Okay, so I'm just going to give you a very quick revision. So we're just going to recap lung profiles because I think it's very important that you know, in particular, what we're going to discuss is the C profile and the different types of C profile, but talk a little bit more in depth about consolidation, atelectasis, and pneumonia. Again, discuss some of the differentials of the signs that we see, in particular with consolidation and atelectasis. Have a chat about static and dynamic air bronchograms, which I completely understand can be incredibly confusing at times, but then discuss the role of clinical correlation. And then we have some cases to show you. So just a very quick recap again about the normal lung, the classical batwing appearance, which basically shows a normal, regular pleural line, which is continuous, smooth, with no breakage, with slides. Then you have the ribs with the basic acoustic shadow, which gives you this kind of batwing appearance. As you all know, it's nothing related to the actual kind of appearance of a bat. It's more related to the fact that the bat basically uses ultrasound waves to kind of locate its prey and targets. So, you know, it's an interesting analogy, but clearly with the batwing sign and normal A profile, as we call it, what you should see is a classical seashore sign, which is because the pleura slides and shimmers on itself. So this is a classical A profile. Again, what you can see is pleura that's sliding really nicely with a few comet tails and parallel A lines. This is an adult. That's why the tissue looks so bright. Now, clearly, what is important is that you should confidently be able to see sliding in every region if you're talking about an A profile and if the lung does not show pathology. And this is important because the absence of lung sliding, as you can see in the slide on the right side, I'm just going to use a laser pointer. So no lung sliding, kind of A lines. The question is whether you have a pneumothorax over here. But the absence or reduced lung sliding, as you can see over here, it's not completely absent, it's reduced, can occur due to a variety of different reasons. Now, if you have a normal A profile, completely aerated lung, any thoughts if your lung sliding is reduced, what the reasons could be? So I'm just going to throw it out there, guys. Feel free to come in one by one. So we've got a normal batwing appearance with an A profile with sliding that doesn't look as good as it should. So what are your differentials? What would you be thinking of? Go for it, guys. Come on.
Pneumothorax?
No, but we have a normal A profile with A lines with sliding. So if you have a pneumothorax, you'll have completely absent sliding, which will give you an A dash profile.
Look, babies who are on high frequency ventilation.
Very good. That's absolutely fantastic. So often babies on high frequency ventilation, and especially babies who are air trapped. Air trapping basically means that the lung can't relax. And for that reason, air trapping can give you reduced lung sliding. Any others? Any other thoughts?
Diaphragma paralysis.
I would say it's tricky one. It's not one that I've read in the literature, and it's not one that I normally diagnose on lung ultrasound, diaphragmatic paralysis, but it's possible. Yep. If I think about it physiologically. Any others?
Consolidation allocate can be, but not with A profile.
Yeah. So we'll talk about the B dash profile, but just a baby who's got very shallow breathing. You know, a baby may have very shallow breathing. And a good example that I'll give you is babies, say, for example, who are born and who might have SMA and who, you know, from our perspective, haven't got the severe kind of SMA, which is tubed and ventilated, or have a myopathy, say, for example. They're very shallow with their breathing, might be breathing 18 to 20 per minute. And because they have such low respiratory rates, the sliding will not be as prominent. And really, again, what I'd say is if you're confused about lung sliding, and you can't say, as you might be the case here, making the baby cry hopefully not with a painful stimulus, but something that kind of makes the baby, will actually exaggerate your lung sliding and make it more clear. So just remember, that's something that you can do if you're worried that the baby doesn't have enough lung sliding. Just a very quick recap about lung profiles. So we've talked about A profile, lung sliding. Now, B profile, classically, we will kind of revise again, but C profile is the profile that presents with atelectasis, collapse, and pneumonia. And then you have this kind of transitioning profile that's not part of the profile described by Daniel Lichtenstein, but is kind of transitioning lung, where you've got A and B. And just remember, when you have a B profile, you don't always eradicate A lines. So, you know, what is important from your perspective is in transitioning lung, you can see A with B profile, like as you see with the double lung point, or you might see a B profile with some intermittent A lines, which gradually improves over time. But if you have absent sliding, as you see with the pneumothorax and a barcode sign, it's A dash profile. And then what I'd say is that if you've kind of got a dominant B profile with reduced or absent kind of sliding, absent sliding, that's called a B dash profile. And in complete atelectasis of the lung, or very severe mnemonic consolidation, where the lung is completely filled with exudate, where air cannot move in and out, you will see a B dash profile. What you might see with that is lung pulse. Because the pleura and there's no aeration, the lung basically, that area of the lung which is collapsed or tends to move with the heart pulse. So that is a B dash profile for you. Now, just going further to the next slide, I'm going to skip this, is to kind of just give you a revision of, you know, this is normally aerated lung here, pleural sliding. You've got, I mean, in my mind, I'm not convinced maybe one area that with the IFA that, but I'm not convinced you have any B lines here. Again, I'm not convinced you have any B lines here. You've got good pleural sliding. Now, this is classically what is a curvilinear probe. Because you have a curvilinear probe, you can't see the pleural line. You can see A lines. Pleural line is just visible at the top. But actually, when you're using a sector probe, you can see pleura here with very mild sliding. These are adults. Now, classically, when you come further down, you can see B lines now appearing with basically A lines that aren't obliterated, but they're less than 3 B lines per intercostal space. And this could be transitioning lung for you. But then from our perspective, if you look at this image here, and I'm just curious, I want somebody to have a go at this. Anybody want to have a go and tell me what they can see over here, guys? So would the lovely Dr. Vijay Lakshmi, can you hear me?
Is that the third or the fourth picture you are asking?
The fourth picture. So can you see my cursor? Can you see my orange laser light?
Yes, sir.
Okay, so what do you think you can see? This is the right upper R1 zone.
Lung sliding is present, sir. I am seeing compact B lines, sir.
Okay, so kind of here. Yep. And what about here?
Subpleural shred sign and subpleural consolidation in the leftmost side.
Okay. Okay, this is right and that's left. Okay, fair point. Dr. Mayank, what do you think you can see over here? Right upper.
So this is appearing a little bit like my image that I had in the R1. So in the upper part, I can see if this appears to be a large consolidation, I think. And then probably there's compact B lines in the lower parts, and the pleura appears to be thickened, and this A lines in the lower part of the image. So the upper part is consolidation, large consolidation, followed by B profile compact B lines with a thickened pleura, and the lower as we go, the normal the lung gets.
Okay. Okay, fair point. Anybody else? Anna, what do you? Yeah, go for it. Yeah.
Sorry, it's Sujit here. So
yeah.
I want to say that so you can see the pleural line stops abruptly.
Yeah.
And to me, this liver looks, the lung looks like a liver. So there is hepatization.
So over here?
Yeah.
Okay.
And I think that what you're seeing there is a bronchogram, probably a static air bronchogram.
So
right in there, yeah.
Yeah. And what about here? What do you think here?
So I think you have atelectasis, and then you have a loss of pleural line. Suddenly there's a dropout, and you're not seeing pleural line.
Yeah. Okay. So there are two possibilities here. You're absolutely right. So we've kind of
hello, can I come in?
Please, by all means. Yes, sorry.
So in the upper part, I agree broadly with Sujit and mine, except one more thing, that there is also collapse, there's subpleural collapse probably, and deeper consolidation.
Okay, over here.
Yes, no, subpleural.
So kind of here, this line that's coming in.
Yeah, around there.
Yeah. Okay, lovely.
And
beautiful.
Also associated the compact B lines that you said could be associated with consolidation.
Yeah. Does anybody think there's a mild effusion there?
Yes, maybe.
Yeah, maybe a mild effusion. So yeah. So I'm just giving you background over here. So this is a baby who's 25 weeks of gestation. Theoretically, from our perspective, this baby was intubated, ventilated at birth, had a dose of surfactant at birth in delivery suite, then had a repeat dose of surfactant at 12 hours and kind of remained in air for quite an extended period of time. About 72 hours of age, this baby started deteriorating with kind of a rise in FiO2 and worsening gases. And clearly, from my perspective, I didn't do an X-ray at that point. I did a lung ultrasound of that right upper zone, and I noticed, and you've got a complete loss of the pleural line there. And again, hepatized lung. You've probably got what looks like a fluid bronchogram in the middle that you can see there. That's a fluid bronchogram. And you've got this dynamic bronchogram. Can you see it goes in and out? It's very difficult to see, but with the eye of faith, it moves in and out over here. Now, no pleural line. And the real debate in my mind is, well, are we dealing with atelectasis or consolidation? And we did a CRP and it's 38. And basically this middle lobe over here definitely is consolidated. I'd say the pleural looks a little bit on the irregular side. So my gut feeling is you could have a consolidation. I'm still kind of unsure from my perspective whether that's kind of consolidation, atelectasis. I think it's a bit of both. And the reason that I have a worry that it's not just pure atelectasis is because you have a dynamic bronchogram, which usually means that air is coming in and out. The reason that favors atelectasis is you have no pleural margin. And I think you have a bit of both. And when you look at the X-ray, which I will show you in the next class, basically we had a right collapse consolidation with a high CRP. And within about 36 hours, I mean, the CRP had gone up. We had bilateral consolidation with this right upper zone consolidation. So very quickly progressing kind of mnemonic appearance. And we grew E. coli in the blood culture. So again, it's just to say, and the reason I'm talking to you about this at the moment is it can be very, very, very difficult to differentiate pure atelectasis from pure consolidation. My experience is they often coexist. And really, the question from your perspective is, do not just exclude a mnemonic consolidation because you do not see shred sign. That is very, very important. But what you can see is B lines have coalesced. And really, from our perspective, you can see progress in B lines over here to the point where you've got white lung, dense white lung appearance at this particular point. AIS over here. This is obviously less than 3 B lines. And this is just progression from an A profile to what technically is a consolidation collapse with an AB profile. Compact B lines visible over here, maybe a little bit of shred sign. So B profiles often, this is just an example of AB profiles that we've talked about. You've got a double lung point over here. And really what we're going to talk about today is the C profile. And classically, from my perspective, the C profile presents with an irregular pleura, kind of pleura that might appear broken patchy in zones with a kind of a B profile. But clearly what I'd say is that when you try to look at sliding over here, it's very difficult. So I would say that I can see more lung pulse, maybe with a little bit of sliding that's visible, but with this large area of what I'd say is a B profile. And then just below the lung in this region over here, I see a region that really looks broken down, irregular, with what looks like a shred sign. And I would really worry. I mean, this entire area is consolidated, and the question is whether there's a mnemonic kind of a consolidation over here. I would be putting Dopplers on it to have a look at the vessels at this particular point. Now, again, very, very important from my perspective is the fact that you definitely don't want to miss a pneumothorax. So, you know, classical truck sign, pleura is not sliding. And really what you've got parallel to each other is lots of A lines. But now, does anybody kind of want to have a go at this? So what can we see over here? So Dr. Uday Kumaran, can you hear us?
Yes, I can hear you.
Okay, so would you like to have a go at this? This is basically an R1 image.
Okay, I'll try. So I see here in the upper zone. So first, pleural sliding is there, and right upper zone, I could see subpleural consolidation, as well as static bronchograms, multiple static bronchograms, and then down, I could see a lot of B lines, maybe compact B lines, and some A lines.
Can you see A lines? Can you see A lines? You sure?
Down in the last, like lower part. Not
I'm not really convinced, but go for it. Yeah. So, okay. So you've described this area. That's beautiful. Dr. Rana, would you like to describe this?
Yeah, so on the left side of the screen, I can see clear lung sliding. On the right side of the screen where the cursor is, I'm not sure about that lung sliding. It seems like just a bouncing pleural line. So whether it's lung pulsating rather than
very
lungs.
nice.
Yeah, yeah, and just beneath that in that area, I think it does look like there is some air bronchogram, not quite sure, probably static rather than dynamic, because I can see them just not changing really. And right there in the middle as well, just behind that second, in there is some deep consolidation. I think it does look quite echogenic and bright there.
Yeah, so very tissue-like. So this entire region looks very tissue-like. You're absolutely right. You can see a pleural line over there. So my question at this particular point is, why isn't this atelectasis? Okay, so does anybody want to have a go? Do we think this could be atelectasis, or do we think this is consolidation?
You can see the pleural margin, which means there is aeration and therefore unlikely to be atelectasis.
Okay, I think that's a fair point. So really, this is the point that's really important, that you can see the distal pleural line all the way through. You've got static air bronchograms. You've definitely got even a deep consolidation coming in, but this entire area looks very tissue-like, kind of hepatized. I'd say you have a B profile. I just wonder, from my perspective, you've got this one B line coming in there, pleural sliding in this region, but no pleural sliding, just lung pulse. This is what you call a classical B- profile. And your differential diagnosis would be consolidation. The point against atelectasis at this particular point would be the fact that you can see pleura all the way through. And if you can see pleura all the way through with static bronchograms, then really from your perspective, there's got to be an element of aeration that's happening. So it would be a point against atelectasis. Lung pulse, we've already kind of talked about. Again, I just, what you can clearly see is lung pulse is basically movement of an area of the lung with the heart pulsations being transmitted to it. So clearly at this particular point, you can see pulsation with the heart margin, but this is very clear lung sliding. And this is it's very important, from your perspective, that you're able to recognize lung pulse. And this is an absolutely beautiful image. If I may, I'm just going to take my cursor off. Sorry, I've just frozen. The computer says no. So, anybody want to have a go over here? So, Dr. Hassoun.
Yes. So with the right side of the, we'll try to first the right side of the image. There is mainly a profile with some comet tail, some beeline appearing, good lung sliding, but at the left side of the image, no pleura. I think there is dynamic bronchogram and B profile on the left side, sorry. So mainly goes with atelectasis.
Okay, so dynamic air bronchograms is usually not seen with atelectasis because nothing can move in and out. Are you sure you can see dynamic bronchograms? I think it just looks very tissue-like.
Yes. Yes, no, you're right, 100%, yes.
No, absolutely. You please disagree with me. I think it's really important. That's how we're going to learn. Anybody else? I mean, what do you think, Shankar, Dr. Shankar?
Yeah, I think the pleura is slightly thicker, and we're losing the pleural, losing the pleura at the top part of the image, and
Yep.
there's hepatization.
Yep.
Underneath, so I think there is a consolidation, quite a big one, I think.
Okay. Could it be atelectasis?
It could be, but I think because completely you're losing the pleural.
So that's my point, that if you're completely losing the pleural line, you're not going to have lung aeration. If you don't have lung aeration and you're losing your pleural line, that goes more in favor of an atelectasis. Whereas if you're kind of in a situation where you can see the pleural line with static air bronchograms, there must be air there. There must be air coming in and out to be able to inflate the lung to produce the pleural line. The presence of pleura basically means that the lung has got to have reached that margin. You have to have air coming in and out. But if air is completely absent, as you see over here, and the pleural margin is not seen, and you have a tissue-like sign, they're both C profiles. But as you can see over here, in this situation, it's kind of a C dash, a C profile. And over here, what I'd say is the problem is you don't see the pleura. So this is more likely to be atelectasis. And it's basically very tissue-like. The hepatization can be part of both atelectasis and consolidation. It doesn't necessarily differentiate them, but the absence of a pleural line basically always, from my perspective, raises the possibility that this is more likely to be atelectasis. And my only other comment is if you have complete atelectasis. So can you see this is lung pulse? So lung pulse, again, is a feature in complete atelectasis because there's no air coming in, there's no pleural sliding. So actually what happens is you can see pleural sliding over here, but you can't see it over here. And this is transmission of lung pulse. So that's atelectasis. Yeah.
And this one, we saw dynamic bronchogram, not static.
Not here. I can't see any.
Here we don't see any aerobronchogram. Yes, right?
Yeah, completely. There's no bronchograms. And we'll come to bronchograms. They will look bright, really bright when there's air, and they will be dark when there's fluid. But can you see how bright these, the way I would describe a static air bronchogram is like stars in the sky. They look bright. Can you see how they, have you ever seen stars twinkling? That's the way I like to describe them. So twinkling stars, the stars are not moving in and out. The stars are just in their position and they're twinkling. So this is a static air bronchogram, these bright areas.
So but static air bronchogram will go against the consolidation, no?
No. So the reason they won't is because with a consolidation, you can have a block of the bronchus, and I'll come to the pathophysiology, but air could still remain trapped within the consolidation, as can fluid. So the presence of a bronchogram, either static or dynamic, can be part of a consolidation, and air can move in and out. The fact that you've just got obstruction of the bronchiole does not mean that air can't move in and out, and I'll explain. So maybe I can do that right now, actually. So
this is we are, yeah, I'm so confused in this one. When
Yeah.
you have a bronchogram, so it's dynamic or static, so it will go with the consolidation or with atelectasis, and how can we rely on each of it?
Beautiful. So that's what we're going to clear up today, and we're going to practice. So what I'd say to you is that if you look at the pathophysiology of a consolidation, now this is basically a bronchiole that's leading to alveoli. Okay. Now, if you have a consolidation, obviously from your perspective, the reason for that is there's exudate in the alveolar space. Now there's exudate in the alveolar space, which is causing the consolidation, but air can still move in and out. I'm really sorry, guys. Just quickly going to take that. Sorry, somebody doesn't like me. Okay, so what I'd say to you is that if this is the area that's consolidated because you've got exudate within it, and air can move in and out, then really that's dynamic air bronchograms for you, coming in and out. So a consolidation can have a dynamic air bronchogram. But at the same time, sometimes what happens is you get blockage of this. Exudate can appear in the bronchioles. It might be partial. And if it's partial, then again, air can move in and out. But if it's complete, you might have air trapped within that area early during the phase of consolidation. Now, because air is trapped and there is some air there, the lung remains, the alveoli remain inflated. They give you static air bronchograms and you still have consolidation. But if you're kind of in a point later on where a major segmental bronchus gets completely occluded and air could not move in at all, then what will happen is these alveoli will completely collapse. And if they completely collapse, then again, what you'll get is hepatization, retraction of the pleura from the pleural margin, and that will favor more of atelectasis. Often, as you progress with consolidation, you will have a combination of both. But if you have complete atelectasis, because this bronchus is completely excluded, kind of occluded, then really you cannot have air coming in and out. So if you cannot have air coming in and out, then you cannot have dynamic bronchograms. Do you get what I'm saying? Are there any doubts about this?
Very
okay.
good.
So consolidation from my perspective basically represents exudate in the alveolar space. And because of exudate, transudate, if you have a pulmonary hemorrhage, well, that's going to be transudate. If you have amniotic fluid aspiration, that's kind of going to be transudate. But kind of anything that causes fluid in these spaces is going to give you consolidation. When these alveoli merge together and there's a large area of continuous alveoli that are involved, and it basically occurs in a lobe of the lung, then it's called lobar consolidation. What we see on lung ultrasound is basically the ability of air to still come in because the bronchus might be patent, as in the early phase. If air can come in, move in and out, then really what you're going to have is dynamic air bronchograms. On the other hand, if you've got exudate that fills, or pus that fills the bronchioles, because you've got bronchopneumonia, then you might have fluid in the bronchioles, but you might still have the ability of air to come out, and air will push this fluid. And if air pushes this fluid in and out, then what you'll have is dynamic fluid bronchograms. So they can also exist. And again, that's something that tends to point towards more of a mnemonic kind of a consolidation. But if you have got complete obstruction of this big bronchial tree supplying these alveoli, they will collapse and you will not be able to have air or fluid moving in and out. So you cannot have dynamic air or fluid bronchograms. But in addition, because the lung is collapsed and there's no aeration, you will not be able to see the pleural line because the pleura is not aerated. The lung is not aerated, so you cannot see the pleural line, and that goes more in favor of atelectasis. It is very, very difficult to diagnose this at one point of time. Sometimes they can both coexist as it's getting worse. Alternatively, what you might find is that you can have areas that kind of overlap. You can have an area of atelectasis adjacent to an area of consolidation. And classically, what I'd say to you at this particular point, when I look at this image, is that you've got a pleural margin that's right up to the top. You've probably got exudate or transudate in the alveolar space, which is causing alveolarization and hepatization, giving you what is called a tissue sign. But there is air still trapped in there, which is giving you those bright, speckled, twinkling star kind of appearances. And these are basically static air bronchograms. Because I can see the pleural margin, I would favor more of a consolidation kind of an appearance. I have a deep consolidation that comes and goes as the baby inspires and expires over here. I'd also say that I think this is consolidation with static air bronchograms. The pleura is irregular. But actually, if I kind of move towards this picture over here that I described, I really worry that I can't see the pleura. There's probably not air going in and out, but this margin here, you've got a dynamic bronchogram that is visible, and I'll make it more obvious. This is consolidation here. So you have atelectasis alongside consolidation here. And the reason I think that's the case is because I can see this small area. I'm just going to use pen over here that moves all the way in. Can you see this area here? So for me, yeah, any questions? Okay, so let's see a few more images. So again, this is what I would say from your perspective is a segmental consolidation that you can see over here. And what it appears as is basically a large area of Coaley's B profile. Depending on how severe this is, the pleura might move a little bit if you have some aeration. But if you have no aeration because there's complete exudate there, then really from your perspective, you might find that the pleura doesn't move, but there's an element of it still present because we're still able to get some air into it. Now, if this is associated with a shred sign and a higher CRP, then clearly from our perspective, the thing that we really worry about is the potential that this might be a mnemonic kind of a consolidation. So consolidation could be present because you have pneumonia, but you can get consolidation from pulmonary hemorrhage. You can get it from other reasons. And this is classically what I'd say is differentiating patchy consolidation from what is lobar consolidation. So I want you to focus on the image on this side. So does anybody want to describe this image? So Dr. Margarita, are you able to speak to us?
Yes. Are you listening?
Okay. Yeah, I can hear you very nicely. So would you just like to describe what you can see? So we stick to the protocol. First of all, start right from the outside. So can you see a bat wing?
Yeah. Yes.
Okay. What do you think about the pleura?
Pleura is smooth and is sliding mostly.
Sliding?
Yes, we see the B line sliding. Not there is an image that is a bit less here.
Okay, but roughly, do you think sliding? Yes, no? Yes?
Yes.
Okay, I agree completely. Some aerated lung in between?
What? There is some,
aerated.
we see some A lines, I think.
Yeah.
And some B lines also, some B lines.
Okay, so I mean, in particular, the first part of the image on this left side, again, it's a B profile with sliding at this particular point.
Yeah.
Maybe a C profile, you know, it's really a lot of them are kind of coalesced together with some aeration, especially in the lower half. If I was to think about consolidation here, this is it's restricted to one particular area at this particular point, but it's quite patchy if I'm looking at it. And really, this is what you classically call is kind of non-translobar. It's not restricted, it's patchy because you have intermittent areas of lung aeration. But what do you think about the image on the right side?
The right side, it has here, it has a tissue sign.
Yep, very good, beautiful.
And we lose the pleural line.
Yep.
And we see some dynamic, let me see better. I think there is some dynamic bronchograms.
Very good.
Okay.
Very good. I completely agree. So can you see the dynamic bronchograms that move in and out? Can
Yes.
everybody see them? Is anybody confused? So they move in and out here.
In the lower part, they see very well.
Yep.
A big one.
Yep. And you've got a very big shred sign.
Yes.
A very big shred sign, irregular fractal sign. Now, this is what I don't want you to confuse with atelectasis. If you have dynamic air bronchograms, atelectasis is unlikely. And some people get confused and think that a large shred sign basically is and might reflect atelectasis. Actually, it's basically lung that's broken down, completely broken down. Because it's completely broken down, you don't see pleura at all. And you see reflection of sound waves, which give you a hypoechoic appearance on what is a very irregular area. Now, I would be putting Dopplers on this and we'll see what Dopplers look like. Any confusion? Is anybody confused? I'd be very worried about a pneumonia on that right side. And that because it's such a large area in one particular region with what looks like, hepatization tissue sign, you can see margins on it. That is likely to be a lobar, translobar consolidation. Anybody want to comment on this one? Anna, Dr. Vaz, would you like to comment on this?
I'm sorry, Alok, I'm not able to talk now.
No problems. I apologize. That's Sujit. Go for it.
So you can see on the right side, the pleural line is thin. It is moving, but the pleural line seems to be preserved all the way through.
Yeah.
But on the left side, you can see the pleura is bouncing, which makes me sort of think more, more in keeping with sort of a lung pulse rather than a sliding pleura.
Yeah.
There is hepatization of the lung tissue beneath with this static air bronchogram. So you get the starry sky appearance.
Yep. So, pneumonia versus atelectasis, your thoughts?
My thoughts would be a pneumonia because I can see the pleural line and therefore that part of the lung is aerated, which goes against atelectasis. And there's also right in the middle, I can see a dense B line there. There's consolidation there.
Yeah. So again, I completely, I would favor consolidation. And as you can see over here, the important thing about consolidation is hepatization. Often kind of without giving you a delineated shape. So, this is quite, I would say, lobar at this particular point. But what it gives you is a liver-like appearance, which is classically described. Now, atelectasis can give you a very similar kind of an appearance. But what you will lose is your pleural line if it's complete and total atelectasis. And just remember, both of them can actually coexist. Now, this is obviously a massive translobar consolidation of the lower left lobe. The gain settings are very high. And again, this is just the image that I had magnified for you. So can you see how the pleura is kind of completely absent the pleural line? And really what you've got is, you've got this area here of a dynamic air bronchogram that's coming in and out. Can you see it right over here? So there's consolidation here, but I just wonder whether that's atelectasis. And this is right upper, this is a right upper lobe kind of a baby with a tube that was quite low, but with an evolving collapse consolidation on that side. And really, just for your knowledge, that from your perspective might be a fluid bronchogram, which is quite unusual. But I think the reason it's visible there is probably because I have a little bit of overlap of my probe with a consolidation collapse. And that's where I'd say that when you have them both together, it can get quite confusing because you've got a dynamic bronchogram coming in. The shred or the fractal sign we've spoken about, it's basically a superficial area of the lung in relation to the pleura where you've got complete alveolar breakdown. And really what it reflects is area between lung that is consolidated and basically an area that has virtually no aeration because the lung is completely destroyed. So this is consolidated lung. This is lung that's completely destroyed. Obviously, a little bit of kind of margin is visible there because there's some air coming in, but it's always commonly opposed to the pleura. And really, if you put some Doppler on it, you might be able to see high or increased vascularity. And this is usually a feature when you see consolidation, if you have a high CRP of what I would say is pneumonia. But pulmonary hemorrhage can give you a shred or a fractal sign with a normal CRP, and you have to clinically correlate. I mean, if you have blood coming up the ET tube, then really what you'd be worried about, again, from your perspective, is potentially the fact that you might have pulmonary hemorrhage as the cause of it. So again, this is just another example of a fractal sign. You've got consolidation. You've definitely got what looks like a little bit of pleural sliding there, but clearly what you've got at this particular point is a tissue sign coming in over here. So there's definitely consolidation. I can't see the pleura there. So the question is that atelectasis, as a differential? You've got a deep consolidation here, but here you've got a fractal sign that is clearly visible. Pleura is destroyed. And really what I'd be doing is I'd be putting a Doppler on this region. Okay, so anybody want to have a go at this? So Dr. Latif, would you like to describe this?
Yeah. Okay. So in this image, I can see the rib shadows, or rib columns. Pleura for me is thick and interrupted at some points, and it is sliding. The profile is predominantly B because I can see some compact B lines, and in the middle of I can see this subpleural consolidation with bronchograms toward the right side of the image.
Yep. So you can see some bronchograms there.
Looks like dynamic because they are coming and going.
No, this is the point that I want to make, and this is why I'm showing you this image.
Okay. So that
the twinkling appearance where they come and go, they appear and disappear is static. They're not moving. They're in one place. So they're not moving in and out. And I'm going to show you a very clear image. But that's a C profile here. And I would agree, you've got a B profile over here. But that's a deep consolidation for you. And just you've got broken pleura with a very irregular margin, which basically is a small fractal sign or a shed sign.
Small,
Just image quality, just commenting on it. It's one of mine. So basically, I need to reduce the frequency to get the deeper areas. The risk is I might miss deeper consolidations. And this is really, 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 really important when you start looking at pneumonia. Please scan all your regions. So R1 to R6, L1 to L6. Make sure you look at the PLAPS point, which, the risk is you can miss small consolidations and mnemonic kind of collections in supine babies if you don't look at the posterior region, which is R5, R6. Okay, this is obviously a subtle kind of a, let's see what an obvious shred sign looks like. I mean, have a look. I mean, this is horrible. Lung is completely destroyed. Okay, so this is a beautiful image. So want to have a go at this? Dr. Hassoun, can I ask you to have a go at this?
Yes. Here what I can say is that fractal sign or shed sign is here with dynamic bronchogram. Otherwise it was a profile, but because the image is acting so fast, so I can't see if the other pleura is sliding or not from the left side. But there is, for me, consolidation this one with a fractal sign.
Beautiful. So what I'd say is that the first part of the image, which appears now, is aerated lung. Then you've got basically what is a C profile consolidation, pleural retraction, aerated lung, C profile, pleural retraction. But can you see this lower margin over here? So can you see how, from your perspective, that pleura that's bright, it's completely disappeared. And then you've got this area where you basically have pleural separation. So there's a little bit of fluid there. And really what you've got is a curtain sign. So there is a synemonic effusion that you can see over here with what is basically lung atelectasis. It's compressive atelectasis secondary to a pleural effusion. And can you see how tissue-like it looks? That's liver, but it looks very tissue-like. So you've got everything that you want. Lung with lung aeration, with what is a lobar consolidation, likely mnemonic because you've got severe shred sign with destroyed pleura. I think if you put Doppler on this, you'd probably see quite a vascular appearance. You basically see a synemonic effusion, which is causing compressive atelectasis, which separates the visceral and parietal pleura, and you've got a small curtain sign that appears right at the bottom. So you can see how this is classically it's a continuum ultrasound that's only possible with more modern machines, where you can actually look through the entire image in one plane and marry the images together. We don't have this facility in our machine, but it gives you what is called a dynamic geographical experience of looking at the entire. This is basically, from our perspective, lung on one side. Now, bronchograms and differentiating bronchograms, just to make it really, really simple. Air bronchograms usually are hyperechoic, dense, speckled. They're like stars in the sky, is the way I like to describe them. If they're static, they twinkle, but they don't move in and out. Dynamic air bronchograms, on the other hand, tend to have movement. And because they move in and out, they exclude bronchial obstruction and make a mnemonic kind of a consolidation more likely. Again, fluid bronchograms are pushed because air is moving in and out. Because the fluid obviously appears hypoechoic, you're kind of in a situation where you'll get a dark appearance. So if you have appearance of shred sign with dynamic air and fluid bronchograms, for me, that really favors pneumonia. And then if you put your Doppler on it and it appears very vascular, then from our perspective, you're really talking about mnemonic consolidation. And I cannot show this better than on this image over here. So what you can see over here on the left-hand side is basically static bronchograms. So they're in one place. These ones aren't twinkling. They're just there because air is trapped inside. But remember, air, when you have, say, partial kind of consolidation, could still, from your perspective, remain trapped and appear and disappear with. But what they don't do is they don't move. So they're static. But if you look at this, I mean, this is beautiful air bronchogram. Can you see how it's like a snake? The bronchograms basically move in and out with inspiration, expiration. And this is classically air bronchograms that are moving in and out. These are dynamic air bronchograms. Now, can I just confirm, is anybody confused about static versus dynamic air bronchograms after having looked at these two images? Anybody? That's good. When we talk about atelectasis, as I've classically described to you, atelectasis is collapse of the alveoli. Now, this might be because you've got compressive atelectasis, because you've got fluid, and clearly what you can see is the spine sign in this image over here that Abhijit very nicely talked about. The spine gets delineated, but a big pleural effusion over here, which is compressing the lung and causing lung to basically collapse. Now, again, what you can see is you can see these bronchograms mostly static. There is the occasional dynamic bronchogram, and this is where I'd say to you, just be a little bit careful. If you have a synemonic effusion, which is causing compressive atelectasis of the lung or collapse, well, you could still have pneumonia, and the portion of the lung that's collapsed could still have contact with the bronchial tree. So you could see static and dynamic air bronchograms with atelectasis when you have compressive atelectasis. But really, if you look at the image on the right, again, you have two separate images. These are two different cases. So you have basically pleura right at the top that's seen. You've got some comet tails over here. I mean, this with the eye of faith is lung that's a little bit aerated. The A lines are not as well visible. I think if you used a higher frequency probe, they would be. But then you've got this area here, what is classically a B profile. And actually, if you look at the pleura, it moves very poorly. I mean, for me, this is a B dash profile. But as soon as you go to the top over here, you've got a C profile. The pleura is completely absent. You cannot see it. And what you've got is you've got these static air bronchograms that are in there. And really what you've got is you've got a little bit of pleural margin that's visible over here. For me, if I put Doppler and I can't see any vasculature on this, this would reflect an area of atelectasis. And this is a right upper lobe atelectasis. And this is just a much better image, which basically is classical atelectasis for you. So the pleura is visible. It slides. You've got a really nice A profile in this image. Obviously, we're using a slightly higher frequency probe. But what you've classically got is complete loss of pleura with static air bronchograms with what looks like hepatization, a tissue sign. And again, if I put Doppler on this and I can't see any vasculature, for me, this really, I'd be really worried this is an atelectasis at this particular point. So it just goes to show you how you differentiate atelectasis from consolidation, but how difficult it can be. And again, what I'd say to you is the movement that you see over here is it's basically because of transmitted lung pulse, as opposed to the sliding that you can see over here. So atelectasis classical features usually, again, tissue profile, the absence of pleura, the absence of sliding, the presence of lung pulse. You may have no bronchograms at all, complete atelectasis, no air, or you might have static bronchograms, but you will never get dynamic bronchograms if you have non-compressive atelectasis. The presence of dynamic air and fluid bronchograms favors consolidation and is seen more in a mnemonic kind of a presentation. And this is just another example of dynamic air bronchograms in a mnemonic kind of a consolidation. So again, what you can see is an area that looks very tissue-like in the lung with air bronchograms moving in and out. And can you see the difference here? This is atelectasis for you. You've lost your pleural margin completely. There's no compression. And really what you've got is you've got consolidation here, but to the point where you've got no air coming in here with a very sharp margin. This is basically the right lower lobe. And what you can see classically is there are no bronchograms visible over here, but there is one dynamic bronchogram just at the margin where you have consolidation with the atelectasis. Again, a much brighter kind of a tissue sign, but the margins of this consolidation have got a dynamic air bronchogram that are moving in and out. So this is consolidation with atelectasis. Okay. Now I'm very curious. So who wants to have a go at this? And I will give you a bottle of champagne if you can tell me what this is.
And I can speak already.
Okay, sorry, Anna, you're not eligible.
Okay.
For the bottle of champagne. So anybody else?
Can I speak?
Yes, sir. Please go for it. So aap champagne peete nahi hai. Dr. Latif does not drink champagne. So
I will drink honey.
I drink, okay. I can.
Okay, we'll have everybody have a go. So Dr. Latif first.
Looks like this pleura is sliding, but it's thick and very irregular, interrupted. The big middle part is broken. And I can see the bronchograms, but bronchogram look like static, not dynamic. And below it is the B profile, compact B line, but bronchogram are also coming down to the lower level also. So I think I can describe it like a Schredt sign.
Okay, lovely. Okay, fair. Anything else? Okay, fair. I mean, what's your opinion over here? Consolidation, atelectasis?
Consolidation. This because this pleura is thick. Pleura is absent in the middle part. It is interrupted. And
so if the pleura is completely interrupted,
so it is more in favor of atelectasis.
Yeah, but you have a Schredt sign as well.
Yeah,
and so I mean,
it is a mixed picture.
Okay, maybe a mixed picture. Okay, fair point. No bottles of champagne there for anybody else so far. Okay, who wants to go next?
Can I go?
Yep.
Well, I can see there is a irregular pleural line interrupted in the middle zone of the video. Also, I can see a hypoechogenic zone above the pleura. I think this is pleural effusion.
Okay, well done, Dr. Mingwa. Okay, Dr. Mingwa, how will I get you your bottle of champagne? Do you drink champagne?
Yes, of course.
Okay. Okay, I will need your address and then I will try and get you a bottle of champagne. Okay, so very good. So there is a pleural effusion over here. Carry on, Dr. Mingwa. Yeah.
And also, well, I can see very static air bronchograms in the image of the shred sign.
Yeah, very good. Fantastic. Does anybody disagree with that, or is anybody confused? Any questions? So what you've got over here is pleura that's separated with an effusion, which is causing compressive atelectasis. The reason you have compressive atelectasis because the lung is obviously kind of pushed by the fluid, but along with that, you've basically got a very large area of what looks like a fractal shred sign, irregular margins. You've got some air trapping in there, some static bronchograms, some air bronchograms, which you can see. And actually with the eye of faith, you have a kind of a dynamic bronchogram that's moving in and out, but this entire area is consolidated. So what you've got is consolidation with a shred sign. So this is mnemonic, synemonic effusion, but there's atelectasis that's visible over here because of compression atelectasis. So you're really not being able to get air into this area. And for me, the real differential, and I'm confused to this date, is should I label this as just a large shred sign, or because you've got a pleural effusion and there is compressive atelectasis here, that this represents an area of atelectasis. And personally, between me and you, I don't think it makes a difference. My gut feeling is you've got shred sign there with some static air bronchograms. But the one thing that might help us over here, anybody want to say, what should we do?
Doppler.
Doppler.
Very good. So let's Doppler the region and let's see, because my view is that if you Doppler this region and you have absolutely no vascularity to it, then obviously it raises the possibility that this is just atelectasis, which I think is highly unlikely. But if I put Doppler on it and I can see vasculature, I mean, it raises the possibility that this is a mnemonic kind of a consolidation. And how do mnemonic kind of consolidations actually kind of present? So, I mean, this is an adult who's basically got a right-sided mnemonic consolidation. As you can see on CT scan, it confirms a high degree of alveolar breakdown with, what is an area of significant consolidation. But when you actually look at the lung ultrasound, again, what you can see is areas of massive shred sign breakdown. The pleura is completely destroyed. You then have these kind of static bronchograms that are visible over there. But when you put Doppler on it, what you can see is vessels. And you can see vessels in a very typical pattern. Now, this is really crucial. When you put Doppler, depending on your scale, if you make your scale very high, you might see vessels in the entire region, which make you feel very confused. So really what you have to do is adjust your scale. And I like to tend to drop my scale between 30 and 40 in this region. And actually, if I can see blood vessel-like images, and even a single blood vessel would be enough for me, in this kind of a clinical picture, I'd be thinking strongly of a mnemonic consolidation. But if there's complete atelectasis with that lung completely collapsed, I'm not going to really see a lot of blood flow within that region. And what does it look like? So again, this is courtesy my colleague, Dr. Abhijit, who's given me this image. So I'd like to acknowledge and formally thank him. But does anybody want to describe this? Anybody want to have a go? Dr. Vaz?
Okay. See, I see a profile that converts in a C profile when the patient breathes.
Yep.
It's a quite rounded image.
Yeah.
I don't know. And
I completely agree.
I see bronchograms. I think they are static.
Yep.
I
Very
don't
good.
see that big movement.
Yeah.
And I'm a bit in doubt if there is a bit of fluid or is just chest muscle? I don't know.
Could be just chest, maybe a little bit because it's hypoechoic. I just wonder
Yes.
whether. So what we're really looking
There,
at is we're looking at
yes.
one rib space as opposed to kind of
Yes.
looking at the transverse image. So, but classically, you're right. So can you see how there's well aerated lung when the baby inspires? Inspiration, 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 inspiration. So when the baby inspires, you get well aerated lung that comes up. But then when the lung kind of expires and collapse, maybe you're right, there's a little bit of effusion there, but you've got this area that's well-rounded, which is basically a massive area of shred sign. Pleura falls away from the margin, and you've basically got static bronchograms. And I'd be very worried about a kind of a focal mnemonic kind of a consolidation there. But classically, and this is what I want to describe, when you actually take your image deeper down into this area, which is also consolidated, which is also lung, you don't really see a typical vascular pattern to it. But the more bright your scale is, actually, it just looks like there's diffuse vascularity. But actually, when you look at this area over here, you can clearly see blood vessels coming into it with increased vascularity supplying that area. And that would favor mnemonic consolidation as opposed to this being atelectasis from the lung margin. Because if it was complete atelectasis from the lung margin, you would not have any vascular supply into it. It can be very difficult, but this is just a very beautiful way of kind of telling you. So last image. So who wants to have a go at this, guys? Would Dr. Uday, would you like to have a go at this?
Yeah, sure. The images are very small. I couldn't see clearly though.
Can you see this image here?
Yes, yeah.
Okay.
And I think the pleura here looks broken, a lot of static air bronchogram.
So can you see pleura?
No, I'm confused actually, really.
Okay, so first of all, let's stick to the protocol. Can you see a bat sign?
Sure. No, I couldn't see the bat
So
sign.
the reason you can't see a bat sign at this particular point again is because we're kind of looking at one space, but we're also using a sector probe. Okay, so with the eye of faith, that's soft tissue. You can't see the rib spaces because this is an adult. And we're basically looking at probably one space between two ribs, one rib shadow coming in over here. This is where you'd normally see pleura. So can you see pleura?
No.
Okay.
No, maybe.
Okay. So does it look bright and shiny? And does it slide? Okay.
No.
So no pleura visible. What do you think this is?
There is some hypoechoic collection, is a fluid collection.
Okay, anybody else want to have a go? So anybody else?
Can it be a tissue-like image?
Very good. So it's a tissue sign, very sickle-shaped margin, tissue sign over here. So do you see any bronchograms in this area?
No bronchograms.
No bronchograms. Excellent. Then you start seeing some static bronchograms here. And what is this? So this is consolidated lung. It's a C profile. And you're at the margins of atelectasis there and consolidation over here with a slight dynamic bronchogram. So in conclusion, what I'd say is that differentiating consolidation and atelectasis can be extremely challenging. Both can coexist. The one thing that I haven't mentioned that I would like to sign off with, that if you have atelectasis in areas that you're concerned about and you're on the ventilator, increasing pressure from your perspective might cause lung recruitment and allow that area to expand so that you're then able to see pleural line. So you might then see a consolidation. So atelectasis can be reversed. Consolidation can change because obviously if you have air coming into a consolidation, but it won't disappear completely, with kind of ventilation recruitment maneuvers, but atelectasis can disappear completely. I think my key take-home message to you is that being able to differentiate them is good, but it might not alter your management. Might alter your management from a ventilation perspective, But because of the difficulty with it, don't stress too much. More importantly, what I would say is that if you've got existing shred sign with dynamic air bronchograms and a vascular Doppler appearance with a shred sign and a high CRP, please think very carefully. This might be a mnemonic consolidation. So that's the presentation. We will practice a lot of this going forwards, especially when we have our revision sessions. But anybody, are you confused about atelectasis, consolidation, how you differentiate them, and how you make a diagnosis of pneumonia? Please let me know now. Any questions?
Can I have one question, please?
Yeah.
So this was very clear, beautiful and amazing presentation. Thank you very much for all the clarification. Just my question about another issue, double lung point. Can we have, because in my practice, I see some TTN baby with, you have double lung point, but you have area of A line, complete A profile, and in the midline, and laterally you can have B line. So like double lung point, but one area is aerated and the other complete whiteout, or many B line. Is that possible in double lung point for TTN?
Completely. Basically, TTN reflects a continuum. And actually, if you look at Jailu's paper, which I'll forward to you, classically what he describes is an early phase where you technically have what is a whiteout along with compact B lines. But as double lung points appear, you have a transitional phase where you can have whiteout with aerated lung. You can have compact B lines with aerated lung. But convalescent TTN usually presents with double lung points, where once you see complete resolution and improvement, the lung would be aerated normally, but might have an interstitial profile with more than 3 B lines, which can persist for a while. But the appearance of AIS, which I find quite difficult to kind of understand when he describes it, he considers the appearance of AIS with aerated lung as actually the convalescent improving phase. So you can see white lung with aerated lung or an A profile. You can see AIS with an aerated profile, or you can see compact B lines, or you might just see areas that, say, for example, have more than 3 B lines with. So you can have that continuum, and you can see all those patterns with transient tachypnea newborn.
And is there also subpleural consolidation? Can we see it even some subpleural consolidation? Some baby also, I've seen some subpleural consolidation at was TTN.
What classically is described from our perspective by Dr. Liu is that if you magnify the image and actually you're convincing yourself that there's subpleural consolidations, but they're less than, kind of 5 millimeters, very small, then that with a regular pleural line, which might be blurred but not irregular, then that goes more in favor of TTN.
Thank you very much.
Yeah, we'll practice. We'll be showing you lots of images, and I've got more cases, but we'll practice. One last question, and I'm grateful for everybody for their patience. Anybody else? I hope that was helpful. I'm grateful, and God bless you. And we still overshot, so I'm so sorry. Thank you, everybody. Have a good day.
Thank you.
Thank you.